Hi and welcome to tonight's stream. I am Dr. Aditya. For everyone who is unversed with me, I am an obstetrician and gynecologist. I am a tutor of OBGY, and hence this stream is a little more special for me. This is not going to be one of those usual streams, those usual live streams that I make. This is going to be something special. Just give me a second, I would want to do a voice check if it is streaming well. Yep, it is. So, this is not going to be one of those usual live streams that I do. I've done plenty of them. But this is something that will always be very special to me and will stay very close to my heart. Now, for those who have known me over the last week and a half, it's been a little tumultuous, not a little, a significantly tumultuous one for me. The picture that you can see over here happens to be of my sister, my first cousin, my first sibling, and my closest one, Sheetal, and someone who I also called as Guddi. So I lost her, and as unfortunate as it may be, the loss was to a pregnancy-related complication. A complication that I probably see every week, 2 or 3 every week. I've been seeing it since the last 5 years, more than 5 years now. And despite that, as they say, destiny, fate is so cruel, I was rendered helpless and there was not much that I could do about it. So today, this session is going to be to talk about those complications, the disorder that she had, and also to tell you all how special she was to all of us in my family. So it's going to be a different kind of session, not purely academic, but yes, I would want it to be remembered. And at the end of this session, I would tell you as to what is the reason that I decided to take this session. And I usually don't do sessions on Sunday nights, but the reason I have decided to do this with maximum availability, I'll be telling you about it as I near the end. So this picture is of my sister. Her name, Sheetal. But Sheetal is something I don't believe I have ever called her, and the name that I always associated her with was Guddi. And this picture that you can see is of her when she was just 4 years old. And this happens to be one of the first pictures that I have in my own album. I have several of them, but this happens to be one of the first pictures that I have. And next to it happens to be the last image that I have with her, and this is from the month of May when she was 6 months ANC, around 24-25 weeks in the month of May. And with her are all of us brothers. Fortunately or unfortunately, it was Raksha Bandhan, Rakhi yesterday, and she happened to be just our sole sister, our only sister, and it's been all brothers after her. And yes, this was at one of the places that we had visited together in the month of May, and it will always remain special for me. So what was her case? What was the case that she was suffering from? Let me just start with it. So to talk about her in terms of obstetrics, she was a 33 years old. At that point of time, or just before her delivery, she was gravid to para 1, living 1, with previous LSCS. Her previous LSCS was done 2 years, a little more than 2 years ago, and that was born out of the last cesarean. The indication for the cesarean that was done was that it was preterm labor with breech presentation. As we all know, preterm labor with breech is always an indication for cesarean section because the head is often bigger than the body, and that can lead to head entrapment. Also, it was an IVF baby, the baby whose name is Kian, whose images I will be showing tonight. So Kian is the name. So Kian was born out of a cesarean section, and it was an IVF pregnancy that she had. She had tubal factor infertility at that point of time, and she had decided to go ahead with an IVF. And as is the norm usually, I would say, in most of the private setups, that they keep a very low threshold for vaginal delivery, she had a cesarean section. So obviously, this pregnancy, the chances of having a trial of labor after cesarean were very low. She was bound to have another cesarean section in view of previous cesarean section. So what happened next? In this pregnancy, the first pregnancy that she had, which was in the year of 2023, the Kian was delivered in the month of July 2023. At that point of time, she didn't have any classical signs of preeclampsia. One thing that she had was uteroplacental insufficiency, because even at 35-36 weeks of gestation, as he was born, she also had a short cervix, so she was in preterm labor at that point of time. When Kian was born, at that point, she also had uteroplacental insufficiency, because of which the weight of Kian was just 1.8 kg. At around 35-36 weeks, you expect the fetus weight to be around 2.5 kg. If you look at her, she is a very small, a tiny female. And for her, at least 2 kgs would have been ideal, but Kian was 1.8 kg, so there was uteroplacental insufficiency, which I might retrospectively think was because of placental factor, but she did not have preeclampsia. And what she had was GDM, but it was also controlled on metformin, so that was not significant. So technically, it was a low risk pregnancy that she had at that point of time if GDM is kept apart. In current pregnancy, though, there were a few things that weren't as normal as back then. What were they? So when she did an anomaly scan, that was done at around 20 weeks, it was shown that the uterine artery PI was around 2.8. The mean was 2.8 at 20 weeks. Now I know that at around 12 weeks, the uterine artery PI has to be less than 2.4, and at around 22 weeks, the uterine artery PI has to be less than 1.4. So this is usually the norm, but still at 20 weeks, it was 2.8. And when it was around 2.8, it was obvious that it was on the higher side, and it indicated that at some point she is going to have preeclampsia, she is going to have fetal growth restriction. In fact, even the current baby's weight that she had at that point was around 10 to 15 centile, which was not as ideal as I would want it to be. So that was the first point when we got to know that the uterine artery PI was raised. Unfortunately, in the first scan that she had done at around 13 to 14 weeks, the NT scan, the uterine artery PI was not done at that point. And due to some circumstances, the uterine artery PI was not measured, and hence aspirin was not started. But aspirin was immediately started when it was detected at this point. But as we all know, ecosprin or aspirin, low dose aspirin, which is given to delay this onset of preeclampsia and fetal growth restriction, it doesn't really work much after 16 weeks. So unfortunately, it didn't work as much as I would have liked it to, but it was expected because it was started at 20 weeks of gestation. But had this uterine artery PI been diagnosed at a little earlier gestation, I wouldn't blame anyone for that. Then I could have started ecosprin, but I don't believe that it would have completely avoided what was to come. It would have probably just delayed it a bit, but I don't think it could have avoided. But yeah, that was the basic thing. And after that, every time she had that interval growth monitoring done, it always showed that the fetal weight was less than optimum. It was almost always less than 10 centile. This continued until 30 weeks of gestation. This was the first point that things started to change. Now, before I talk about how the things started to change, the voice is echoing, everyone saying. I'll just switch off my earphones. So yeah, if I'm to talk about 30 weeks of gestation, I've just removed my earphones. I hope the voice is clear now. The voice is clear now, I hope so. So yes, at around 73 weeks of gestation, I hope the voice is clear now. Yeah, it is clear now. So at 30 weeks, a few things started changing. What were those few things that changed? So the first thing that changed, now before I come to that, I have to say that this happens to be one of the first images that I have of my sister. Over here you can see that this is my sister Sheetal, and this is my mom, and this is my mom wherein I, Aditya, am in her uterus. So yes, this is the first image that I have of her, wherein in her preconceptional period, or rather her prenatal period of my mom, she was still around. And this happens to be a 4-year-old Sheetal. And this picture is just the beginning of how she was always going to be around me for every single point of time. After that, I was born. My mom had similar factors. She also had preeclampsia. At term, I was 2.7 kgs. My mom was quite a healthy woman, so I would expect her to have a baby of around 3.2 kgs. But she was delivered, and she had delivered, and I was just 2.7 kgs. Now, at this point, you could see this is me, and this is again Sheetal. This is what we call as a barsa, or the naming ceremony. This happens to be my great grandmom and my grandmother over here, my mom's mother. And she was one of the first people who had even held me in the hospital. Of course, there's no picture of that. But this was like a very symbolic thing, that she had always had me very close to her. She was always there to protect me, and one of the first people who held me. So this is the picture that I had when I was born, and just 2 months after that, when my naming ceremony, when I was named Aditya, and she was there at that point of time as well. After that, for every single thing, this happens to be the image wherein Raksha Bandhan, my first Raksha Bandhan in the month of August, even at that point when I was 6 months old, which also coincided with the weaning process, the weaning ceremony that we have, the weaning ceremony wherein the kid is given its first food. She was the one who had tied me the Rakhi at that point of time and had also fed me. So she's also one of the first people who had not just held me, but had also fed me my first ever morsel of food. And that is how she has been always very, very special for me. There have been several memories of her. This is me with her on her dad's bike, a very classic Suzuki at that point of time, and several memories together. I don't believe there has been a single occasion when she has not been around me. And be it all my vacations, be it all the significant events of my life, she was around me. Now, coming back to her case, what was the case about? So at 30 weeks of gestation, which was, I remember, around 8th of July 25, she messaged me that Aditya, as you have told me that I'll be having hypertension, preeclampsia at some point of time. I have been measuring I had asked her to measure her blood pressure at least once to twice daily as per her convenience, and she said that Aditya, uh, I am starting to get those values which are higher than normal. So on the 7th of July, first of all, she gave me a value of 128 by 86. I told her that 128 of 86 value is okay, it is not that significant, and you can still keep monitoring, but then you would just have to make sure that you're monitoring it twice daily, and it cannot be once or twice. It has to be at least twice daily, once in the morning, once in the evening, or at night before you sleep. On 8th of July, she told me that for the first time her BP was 144 by 99. I still have that message wherein she told me that this is her value. Now, at this point of time, obstetricians usually tell the patient to take a few measures like restricting salt in the diet or just keep on monitoring. But I am a little bit of an aggressive obstetrician. So, me, with the consultation of her obstetrician, who she was showing to in Pune, she stays in Pune, by the way, we decided that we will start her on labetalol. We were convinced that given that she has already had changes in her uterine artery PA and she was going to have preeclampsia at some point, we decided to start her on tablet labetalol, or tablet labet, or lobet as we know it. So 100 mg twice a day was started for her. Now, when we started to give her tablet labetalol 100 mg twice a day, her BP immediately got into the normal range. I wouldn't say normal, but normal for preeclamptics, which was between 120/80 to 140/90. Not again did her BP ever go beyond this. So it was being maintained exactly in this range until the night of 1st of August. That is when all hell broke loose. On the night of 1st of August at around 12 a.m., or I would just call it 12 a.m., so it was around 2nd of August, 12 a.m., she started having projectile vomiting. Now, just a day ago, she had been to the obstetrician, and at the obstetrician, her obstetrician, I wouldn't name the obstetrician, he has done a great job. He is a senior gynecologist in Pune and he has done a fabulous job throughout both the pregnancies. Um, she had a visit over there, and her BP, as expected, was monitored to be in the normal range, so no changes were done. A USG was done, which showed that the current baby's weight was 1.1 kg on USG at 32 weeks. Now 1.1 kg at 32 weeks is far from normal. It is less than 10 centile. We knew this, that it is less than 10 centile. That let me assume that less than 10 centile was significantly low, and a normal, I would say 50th centile is around 1.8 to 2 kg. So what the baby should have been 1.8 to 2 kg, it was in the range of 1.1 kg, 1.1 to 1.2 kg, but the Dopplers were normal, and hence we of course didn't choose to terminate. We just decided that we would do Doppler every week. This was a day ago, but on this night she had projectile vomiting, multiple episodes of projectile vomiting, and she also started experiencing retrosternal burning sensation. She thought initially that those projectile vomitings were because of some sort of food poison, may have been, and due to multiple episodes of projectile vomiting, she believed that it might have led to hyperacidity, which a lot of people, a lot of laymen do believe. But because it was intractable, she was immediately taken to the obstetrician, and at 2 a.m. at the obstetrician's hospital, they gave her the diagnosis of severe preeclampsia. Her urine albumin as well, which was normal until then, which was until normal or trace. You need to know that usually proteinuria is present during pregnancy, but at this point it was +4, which is quite significant. Now, when I say preeclampsia or severe preeclampsia, what is this? Now, a few basics. Now, this is my uterus, and this is my uterine artery that supplies my uterus from both the sides. Now, this is my placenta over here. Let me assume that this is my placenta. Now remember that if this is my normal uterine artery in a non-pregnant female, in a pregnant female, you have to understand that the uterine artery का job is not only to supply the uterus but to also supply the baby. So इतना पतला सा और just this wide diameter वाला जो vessel है uterine artery is not going to be sufficient to supply the uterus. Its diameter will have to increase. But how do you increase the diameter of a vessel that is already present in your body? How do you make a vessel that is like this since several decades, since several years, become larger in diameter? So the body has a mechanism. What does the body do? This placenta has something called as trophoblasts. They are specialized cells that have a lot of functions. One of the functions is, you need to understand that every vessel has 3 layers. This is your tunica adventitia, then you have your tunica media, and inside you have your tunica intima. This is your tunica media and this is your tunica intima. Your tunica intima is made up of a single layer of cells called as endothelium. So what does this, it is there on both the sides of course, and the blood just flows through this direction. So what these trophoblasts do is, they destroy the tunica intima and the tunica media, and all they leave behind is the tunica adventitia. This is what they do. The tunica adventitia is like the wrapper. It is something that wraps my vessels and it just leaves behind that. So earlier, what was only this much of a diameter has now been increased to this bigger diameter. Why? Because 2 layers have been destroyed. One more important thing is that the tunica media contained smooth muscles. Now smooth muscles are responsible for contracting and increasing or decreasing the diameter of the vessel. So once those muscles are removed, your vessel cannot constrict, and if it cannot constrict, then it will ensure that the fetus gets unhindered blood supply throughout pregnancy. So what in a normal pregnancy will happen is, this vessel diameter is going to increase this way because of the destruction of 2 layers, and now the blood flow is also going to increase and the fetus is going to be able to survive. But this is what happens in normal pregnancy. In preeclampsia, there is a defect in the placental formation since day 1. Due to some genetic defect, there are several genetic loci that have been found. There is a problem with these cells. These cells that you can see over here, these cells are problematic. The trophoblasts are problematic and they are unable to destroy the tunica intima and tunica media. What this leads to is going to be, my vessel, which was supposed to become a vessel of wider diameter, does not become that and it remains smaller. So instead of this happening, the vessel still remains of the existing diameter, and this is going to be problematic. Why is it going to be problematic? My placenta, which was supposed to receive a lot of blood, is not receiving adequate amount of blood, so the amount of blood in my placenta is going to be low, and low blood equates to low oxygen, and low oxygen is called as hypoxia. So there is going to be placental hypoxia. Now, hypoxia or less of oxygen is very toxic. It is going to start killing the cells inside the placenta, and this death of several cells or this hypoxia starts releasing several factors. Two of those factors include soluble FMS like tyrosine kinase 2 and soluble endoglin. These are the two factors that are going to be released. They are also called as the anti-angiogenic, or basically factors that are dangerous to the vessels. What do? They destroy two factors in my body that were really good. The two factors that were really good were vascular endothelial growth factor and placental growth factor. These were two really good factors that were helping my blood vessels stay normal, and these are going to destroy them. What does this destruction lead to? This destruction leads to the damage to the endothelium throughout all the vessels in my body. All the vessels in my body are going to suffer damage, what we also call as endothelial dysfunction. That endothelial dysfunction across all the blood vessels in my body is going to reflect on all the organs. How is it reflect? How is it going to reflect? In my circulation, because of this endothelial damage, it is going to lead to hypertension. Hypertension in pregnancy will be called as preeclampsia or gestational hypertension. Next, it is going to damage my kidneys. How is it going to damage my kidneys? You already know that we have this Bowman's capsule, and inside that you have your glomerulus. This glomerulus is made up of just capillaries, only and only endothelium. So when these two factors are going to destroy your endothelium completely, it leads to endotheliosis in the kidney. This endotheliosis increases the distance between the endothelium, and all the proteins from your blood are going to be excreted through the urine. This leads to proteinuria. So basically, because of damage to your kidneys blood vessels, the space between those vessels increases, and the proteins which usually will not escape your blood vessels start escaping them, and you will start having proteins in your urine, also called as proteinuria. This is exactly what she had at the time of admission. She had a proteinuria of +4, very significant enough to ensure and tell me that she is having renal damage now. Apart from that, in her liver, it leads to damage, hepatocellular necrosis. How? Now I know that my hepatocytes or my liver cells are hexagonal, and at these hexagonal ends I know there is a portal sinus. The portal sinus contains the hepatic artery. Basically, oxygen comes from the periphery to inside. Now my hepatocytes have 3 zones in it. We all know that. This is the zone 1, zone 2 and zone 3. So obviously the oxygen reaches the third zone first, and the first zone is going to receive the oxygen last. So whenever there is going to be any blockage to the blood flow, that will ensure that this zone, the innermost zone, is receiving the least amount of blood, and this starts necrosing or dying. This is called as hepatocellular necrosis. It is a form of coagulative necrosis. So basically, because of lack of oxygen to the center and then periphery, these hepatocytes start dying. When these hepatocytes start dying, these cells start lysing out, and they start releasing factors. The factors that are released include SGOT, SGPT, and also a bit of LDH. But very importantly, SGOT and SGPT are going to be released by the hepatocytes, which is also why we say that the patient is going to have increased transaminases, exactly what my sister had. I'm going to show you all the reports, all the trends of the reports that she had. Also, because there is endothelial damage, the body knows that my endothelium is being destroyed. So I need to somehow repair this. So the repairing happens by coagulation cascade initiation. So basically, my coagulative factors are going to come, and they are going to seal these defects off. This sealing leads to one problem, that it uses up all my body's coagulation factors. So once these body's coagulation factors have been used up, it leads to a depletion of my coagulation factors in the body. And this will derange my PTINR. This will increase my PTINR. Also, it will reduce my platelets, because platelets are going to be used in the coagulation. This will lead to thrombocytopenia. Also, fibrinogen, which is used to form a mesh of these platelets, is going to reduce, leading to hypofibronegemia. Now, when these platelets and fibrinogen are going to lead to this mesh formation, my RBCs are going to get trapped over here. These RBCs are going to get trapped over here and they are going to be broken down. This leads to hemolysis, or better called as intravascular hemolysis. Intravascular hemolysis leads to the formation of cystocytes. Cystocytes are broken RBCs. Once my RBCs are broken down, it leads to the release of a hormone called as LDH. So the LDH levels start increasing. So by the time we reach this phase, we know that several enzymes are increasing in the body. It includes my LDH, it includes my SGOT, it includes my SGPT, and apart from that, my platelets are falling. So thrombocytopenia and a raise in INR is going to be found. Now the moment the protein content in my blood vessels starts going out or starts going down, the oncotic pressure is going to reduce. What is the oncotic pressure? What is oncotic pressure? Is basically, if this was my blood vessel and this was my protein, this used to bind to all the water molecules around it. But the moment the proteins in my body start going down because of excretion from the kidneys, this water will have nothing to hold it inside the vessels, and all of this water is going to start going out of the vessels. It starts transudating out. It starts coming out of the vessels, and that leads to collection of fluids, where all it will collect in all your cavities. It can be your peritoneum, it can be in your pericardium, it can be in your pleural cavity. So basically all the fluids are going to come out into the spaces. It is also going to be there beneath her skin. So there is going to be subcutaneous edema. These patients with preeclampsia are often swollen patients. They have very tense skin. You see that they're all bloated, they're all swollen up. This is the reason. Because of the lack of proteins in the blood, all the fluid is going to come out and it's going to lie beneath the skin. Apart from that, it will also lead to edema. The coming out of fluid is called as edema around the brain. Now, because this edema is because of the water coming out from my vessels, it is called as vasogenic. Vaso is vessel, genic is generated. So, edema that is generated by the vessels is called as vasogenic edema. And in the brain, one of the first changes that I'm going to have is going to be vasogenic edema. Now, what happens because of vasogenic edema is, if these are my two cerebrum, because of all this water content around them, the neural endings, if these are my nerve endings that are present above on the surface of my entire, if this is my brain and all the neural endings are present on the surface, collection of water around them leads to a multiple level of stimulation. जो सारे आपके endings है, nerve endings है, they are going to get stimulated, and that stimulation is going to result into GTCS. GTCS is generalized tonic-clonic seizure. She is going to have convulsions, or what we also call as eclampsia. This is also what she had. Remember that whenever this is also happening, there is excessive pressure on my brain. Why is there pressure on my brain? Because there is fluid collection around my brain, and because of this fluid collection around my brain, remember that there is increased chance of increased intracranial tension, and increased intracranial tension से patient को होता है vomiting, projectile vomiting. The first sign that she had was in fact because of this fluid that had accumulated around the brain. The intracranial tension had increased significantly, because of which she was having all those episodes of vomiting, which was later followed by the episode of convulsion or eclampsia. Now, if this blood pressure is not controlled, hemolysis is one more thing that I didn't write here. So if this blood pressure is not controlled, remember that all the tiny vessels are going to start rupturing out, and few of the tiniest vessels are present inside the brain, especially the lenticulostriate vessels that are present around the brain stem, the midbrain. Those are going to get ruptured. A rupture of these is going to lead to something called as brain stem hemorrhage or intracranial bleeding. Intracranial bleeding happens to be one of the last things that can happen in a person with sustained hypertension. So remember, if a person is going to have a very poor control of hypertension, or if despite all the medications the hypertension is not getting controlled, then it is going to lead to rupture of all the vessels and bleeding inside the brain. This is the same fate that my sister had. Now I will be showing you a few more of her images, and I will also show you what her reports said. So going back to the memory lane, this was the first picture that we had together. Now this image, just coming back to the memory lane, happens to be of the thread ceremony that I had. A thread ceremony is a ritual that we have in my community, and in this she was a Karavli. Karavli is one of the females that we call over for the ceremony. And here she is drawing a swastik on my feet. It's a ceremony that we do at the age of 7 years. So I was 7 at that point of time and she was just 12 years old. In 2016, she found an able bride, an able groom, and in 2016 she had her marriage, and she married someone who I believe is the best possible bachelor that was available at that point, Ajinkya. Now, there's a small story that comes up whenever I talk about her marriage. Now, it was 2016 and it was at the same point of time when I just started to lose my hair. And I was quite disappointed, I was quite upset over it, and it used to really depress me to see that I'm having consistent hair fall. And she knew about it. And she would often joke about it, but she knew about it, that how it distressed me. And that was the first time that she on the occasion of a marriage just took me to an amazing salon in Pune, and on me we got volume increase, perming and all those things done to my hair, and all of a sudden it didn't look like the Aditya Nimkar who was having hair fall, and instead the Aditya that thanks to that salon therapy that the people could see was someone with a lot of hair. I had a great increase in volume in my hair, and all the chemicals that they put to keep my hair just stagnated वैसे का वैसे ही रखने के लिए, everything, it just made me look really good, and hence it happened to be one of the best hair days that I've ever had. It was so good, in fact, that I didn't have a hair shower for the next 2 weeks. But the day I had my hair shower, when I was back from a marriage, I lost probably 50% of my remaining hair, and that was literally a nightmare that day. But yes, this is a very interesting and amazing incident that I remember about her marriage. That thanks to her marriage, all my pictures in her marriage were really good. And the reason that they were good were that she took me to that salon, which did everything to make me look really good for those 2-3 days. So Ajinkya, her husband, who I now believe is one of the best men that I have known, and they both met each other, and 2016 a big fat Indian wedding in Pune, and from that wedding they had their firstborn, whose name is Kian. Kian, their firstborn, very healthy, naughty, and an amazing kid. Now Kian was a very gentle kid, a very gentle boy, and he was very scared of coming to people who had a beard or who were a little dark skinned. He just wouldn't go to those men. And unfortunately, me being someone with a lot of beard, he was very scared to come to me. So for the last 2 years, I attempted taking him a lot to just get him to me. I even bribed him with chocolates, toys and everything, but nothing worked. He would just refuse to come to me. But as luck would have it, the day she had her demise was the first time that he came to me, and he didn't cry even once. And not just that time, every day after her demise, he has been coming to me and he has not cried even once. And she tried to make this happen for the last 2 years, but unfortunately, for whatever as rotten luck I might have, he just refused to come to me. He was very scared of me. He would cry immediately, but he has just not cried since the last week, since I've been taking him. So this is Kian, and a very sweet kid, amazing boy. I just love him. I've always loved him, but I think he has just started loving me since the last 1 week. And this is a picture of them three, a very gabbu, chonky kid, heavy kid, and he would just love her mom. I mean, my sister's skin was amazing, and he would love playing with her cheeks. He would just keep on pulling it all through the night. He would hardly let her sleep. And this is one of their images that they had gone together on a vacation. Now, coming to the case. Now, you could see this is her trend. The monitoring of her blood investigations. This is second at 2 a.m. when I said that she had just come, and the blood investigations that showed, whereas this is of second after her cesarean section. Her cesarean section took place around 5:30 in the morning. After all the blood products were arranged, she was given magnesium sulfate. Now magnesium sulfate, as we all know, or Maxilf as we all know, is a drug that is used to cause neurostabilization. It calms down all the nerve endings. So whenever you give magnesium sulfate, it has 5 actions: adenosine potentiation, glutamate inhibition, calcium channel blockade, and GABA B augmentation. So all these actions are going to an NMDA antagonism. All of this ensures that all those nerve endings that were stimulated for the GTCase, they are prevented and they are stabilized, so they won't be that easily stimulated, and it just somehow avoids or tries to avoid the episode of convulsion or the episode of seizure. But magnesium sulfate has its own limitations. It is not the drug, it is not an ideal drug that is not going to prevent in every case. But before going there, I would want to see, or I would want to show you what are the trends that she had. So the first thing that we can see is her hemoglobin, which was fairly normal. But remember that because there is loss of water from the cells, there is hemoconcentration. So this 12.4 may not really be 12.4, it could be something around 10, 11. Because of hemoconcentration, it is looking 12.4. The next significant things that I would want you to see is the platelets, which were 1,77,000, but after the cesarean section, which didn't have any significant blood loss, was 83,000, and it never recovered. You see, despite SDP, RDP, everything that was given to her, her platelets stayed low. So she already had low platelets. Apart from that, her LDH levels, which the normal of which is around 600, her levels were 2,430. 2,430, thus these levels are almost 4 times of the upper normal levels, or the levels that are required to give the diagnosis of something called as HELP syndrome. Significantly high. We didn't test it again because there is no value of testing it again, but it significantly indicated that there is lysis of several cells in the body and not just hemolysis. Because whenever you have HELP syndrome wherein there is hemolysis, these values don't increase as much. This indicated that there is a lot more cells. There are a lot more cells that are dying, that are breaking, which is why these levels were almost 4 times of the already abnormal levels. So what I also have over here are signs of hemolysis. Next that I can see over here, I'll just skip to this part. The SGOT and SGPT, again they are in 800 and 1000. Now the abnormal levels, what we say, are twice of upper normal level. So basically anything more than 70, 75 are said to be abnormal. These are in the range of 816 and 1000. This is literally equivalent to her having some form of liver inflammation, complete liver inflammation. I wouldn't really attribute it purely to HELP syndrome, but yes, elevated liver enzymes. And this actually completed the classical picture of HELP syndrome. She had HELP syndrome, a severe form of preeclampsia, but it was not just HELP syndrome. The hemolysis was significant. The elevated liver enzymes were almost 10 times, more than 10 times, almost 20 times of the upper abnormal limits, and the platelets that was significantly down. And now this made us start thinking that are we really looking at something like HELP syndrome, or are we looking at something else? That is when we decided to look at other parameters. The urea and creatinine were thankfully normal. They had briefly increased, but fairly they were normal. Then came a big breakthrough, the ammonia levels. The ammonia levels, which were around 500, were significantly increased. Now ammonia undergoes deamination in the liver. So basically it is broken down in the liver, and the only reason in which ammonia can increase in the body is when you are having hepatic dysfunction, and hepatic dysfunction is never going to happen in HELP syndrome. It will only happen when the entire liver is damaged, and this was the first clue towards what we were fearing, or what we didn't even want to think might happen, that is AFLP. She was classically going into the picture of AFLP, that is acute fatty liver of pregnancy, the diagnosis of which is given by the Swansea criteria. The Swansea criteria that she eventually fulfilled, but yes, she was significantly going there, and at these levels, these high levels, the patient is going to have hepatic encephalopathy. So basically the patient is also going to have damage to the brain because of these high levels of ammonia. Apart from that, Several other parameters were measured. The bilirubin, which was normal initially, had started increasing significantly. This was the peak wherein it had crossed even 8. Increased bilirubin, such high levels rarely seen in HELP syndrome. We do not see such levels. Those levels in HELP syndrome usually are between 1 to 2, not more than 2 ever. But 8.28 were definitely pointing that the liver is not able to conjugate the bilirubin. The unconjugated bilirubin is accumulating in the body, and this was definitely much more than HELP syndrome. It more or less confirmed our diagnosis of AFLP, acute fatty liver of pregnancy. Apart from that, we could see every single levels. Apart from that, we could see that the INR was just around normal. It was not completely normal, it was just around normal. And one more important thing, the urine albumin levels were +4. Now we were looking at a picture of AFLP versus HELP. Both could have been concomitantly there, but the management was going to be the same. And a cesarean section was done. She had an uneventful cesarean section. They were expecting that the patient might have excessive bleeding, and we might need to do, for traumatic PPH, we might need to do obstetric hysterectomy. Fortunately, in fact, it was prevented. But yes, she had a cesarean section, and there's a memory about her that when she was small and when she was just growing up in her formative years, she was a very tiny girl. Even in comparison to her classmates, she was a little tiny. She was tinier than them, very fair and very soft. Her skin was amazing, which is why she got a nickname of Mau. Mau in Marathi is a name that we give to cats or kittens, money mau we call them. And she was called Mau because she was soft, and also because she was a lot like cat. She was very swift. She had often won many accolades in running. She had several trophies in running competitions. She was very swift. So whenever we would all play pakada pakadi, which is just catching the other one, it was very difficult to catch her. Even for me as a guy, it was very difficult to catch her. And she had gotten that name of Mau, and everyone called her Mau. So when she had delivered, and when she came out of the OT, and when she regained her consciousness, she said, the last line in fact that she said to her family, to our family, was that "Baga tumhala dusri Mau ali," which means that, see, I have given you yet another one like me, Mau. She had delivered a female child, and she said that I have just given you yet another form of me, another Mau. And as luck would have it, the daughter that she delivered happens to only be the second daughter in our family, because there have all been brothers between her birth and her daughter's birth. Everyone, all of them have been only boys, and it's been a pure boy family because of that. Now, when she was saying this, she was complaining that she is having headache. They were consistently trying to give her injection labetalol. Even nitroglycerin drip was started for her, but her BP was consistently at around 200, 120. It was coming down to 160, but it would again go up. And that hypertension was just not getting controlled, and that was becoming a cause of worry. 4 hours after a cesarean section, around 10-11 a.m., she had an episode of apnea, or an episode of breathlessness, and along with that she also had an episode of GTCS, that is generalized tonic-clonic seizures. A diagnosis of eclampsia was given to her. But in eclampsia, you do not have apnea. Apnea is not a common finding that you have after eclampsia. A lot of females have. We were expecting that she will have eclampsia, and magnesium sulfate was being given. We would have given another loading dose, Zuspan and Pritchard. She was given by Zuspan. We did expect it, but what we didn't expect was apnea, and she couldn't breathe. So she was immediately intubated, and she was put on mechanical ventilation, volume mode of ventilation. And as is the protocol, after a few hours, we decided to do her CT scan, non-NCCT. Now, CT scan or MRI venogram, wherever MRI is available, is a routine thing that we do for all patients after their episode of eclampsia. It is a personal thing. Most of the guidelines don't say that you have to do it, but I personally believe in doing it, and you should do it so that you rule out all other causes of the seizure. You do not want something like CVST, that is cerebral venous sinus thrombosis, or you do not want something like stroke or anything of that sort in your patient. So I always do an MRI venogram if I have the facility, or if not, at least a bare minimum non-contrast CT of the patient after an episode of eclampsia. We usually do it when the patient is stabilized after 2 to 3 days, but because she had that episode of apnea, we just said let us just do the brain CT, and let's be sure that it is just eclampsia and nothing else. We were all happy. We had all bought sweets and everything. We were tense. We were very tense. That is also when I just reached Pune. We were very happy that a daughter is born. A daughter who I will tell you who was she. A 1.1 kg daughter was born who was kept in the NICU. The baby cried at birth. She saw the baby's face intraoperatively. She cried and she was very happy. And it was done under regional anesthesia because she didn't have papilledema. Uh, the baby was shifted to the NICU, and we decided to do an NCCT, and the NCCT, the non-contrast CT, revealed this. It shook us to the core. Now over here you can see that I have put in two images. This is of Sheetal, and this is a normal image that I have taken of a normal patient. This is not of Sheetal. You could see, first of all, in the normal, these ventricles, these lateral ventricles that you can see, you could see in her, there was gross intraventricular hemorrhage. You could see that all the ventricles were covered. Apart from that, you could see this is the brain stem, midbrain, everything. Unfortunately, over here you can see that there was significant bleeding that was completely covering her brain stem. In fact, it had even extended to the midbrain and the cerebellum and medulla. In a lower down plane, you could see around the brain stem level there was bleeding. All those hyper dense spots were indicative of gross hemorrhage that you could see. And this is your picture of normal, wherein you cannot see any hyperechoic spot. Comparison is with this. It shook us. When I entered the room, she was in the ICU and the doctor called me in and he showed me these images. For a moment when I was walking in and I looked at the light box, I just thought that it might be of some other patient in the ICU, because from far away I could see this intraventricular hemorrhage. I just thought it might be of some other patient, but when I came closer and he said that this is the CT, I just felt that it might be some low quality CT, which is why I'm getting these artifacts. But no, all my worst of my fears came true. In fact, I told everyone that she's going to be fine, absolutely fine. I've looked after hundreds of eclampsia, I would say. Probably I'll reach, the number is going to be around 500, I would say, not even hundreds. None of them had this episode. A few of them did have intracerebral bleed, but none of them had brainstem bleed. All of them had cerebral bleeds, which after recuperation, rehabilitation, physiotherapy, all of them recovered. But this gave me a shock. Everything that I had in me as an OB/GYN, as an obstetrician, just got lost. I didn't feel anymore as a clinician. It just shook me. I froze. Of course, the relatives, none of them are doctors. They were being told about the prognosis and they couldn't understand what had hit them, and they couldn't understand what is this brainstem, what is this brain hemorrhage, how is this happening. I just took them out and before talking to them, I sent this image to a few of my colleagues, neurosurgery and neurology, neuromedicine people. All of them told me that the prognosis is going to be very poor. The prognosis is going to be so poor that even if she survives, even if she makes it, she's going to be in a vegetative state for the rest of her life. And in fact, death is the best outcome for such patients. I couldn't believe my ears. Of course, as a clinician, I need to be acquainted to this, but these are those kind of CT scan images that I see in an 80-year-old, in a 90-year-old who has had chronic hypertension since 50, 60 years. I do not expect it to see in a female who's my sister and who's just 33. But this just shook me to the core and I just had a moment aside and I took some time to come to terms with this. And yes, that moment is something I'm never going to forget. And it is something like we take it out of granted for all our eclamptics. And remember that eclampsia is not the cause of this. The seizure is not the cause of this bleeding. This bleeding was because of the persistent hypertension that she had, which was just not being controlled. And this is the reason she had it. I will not blame the eclampsia because the eclampsia doesn't do this. But this is the outcome that she had. Eventually, we spoke to the neuromedicine, neurosurgical people, and they said that we can do nothing. One of the options was to put in an EVD, that is extraventricular drainage. We drain the ventricles, but the problem was not the ventricles. Ventricles में तो इसलिए आ रहा था क्योंकि brainstem पूरा bleeding से भर चुका है. The damage to the brainstem is irreversible, and she has lost her respiratory drive completely. And he said that as is the protocol, we will just wait for 24 to 48 hours and after that we'll just see what happens. It is more or less not even in hope, it is just protocol for which we have to wait. Everyone had hope. We spoke to almost 10-15 neurologists all across Mumbai, all across Pune. We went to meet a lot of them in Ruby Hall Clinic, in Sahyadri, all those hospitals, all the topmost hospitals in Pune. But of course, it was not going to change. It was more out of despair rather than hope. And we knew that the imminent future was right in front of us. Now, at this point, we realized that she is having this brainstem death was inevitable, but her cardiac failure was not there. Her heart was functioning normally, she was not requiring any inotropes. But remember that the autonomic nervous system that I have, my autonomic nervous system is also going to control my blood pressure, and the autonomic nervous system has a few of its component in the brainstem. So eventually she was going to have hypotension, she would have required inotropes, then she would have had cardiac failure as well, then she would have been dead completely. We decided that we cannot get her back, we cannot salvage her anyway. But the one thing that we could possibly do at this point was she has a fully functioning heart, her kidneys have recovered, the kidneys have been normal, and what we can go ahead with was possibly organ donation. And we decided to just discuss it. It took a great amount of effort from all the people involved. There were a few factors that we were thinking of might be a problem, but everyone agreed. And remember that she had not passed away, she had not had cardiac failure, it was not going to be a cadaveric organ donation thing. It was going to be a live patient who was going to be taken up, and the heart was going to be clamped and dissected. We shifted the patient to Ruby Hall Clinic, which is one of the best hospitals in Pune, and at that point we agreed that we will go ahead with an organ donation. And on the 5th, the morning of 5th of 5th, is it 5th? No, on the morning of 6th, in fact, we decided that the surgery is going to be done. We signed the consents and everything were done as per the Organ Donation Act, and she donated her heart. As luck may have it, the cardiac transplantation was done right in front of an OT that was right in front of the ICU where she was kept. And the cardiac recovery area, the patient was also there, but obviously, as the norms are of anonymity, we do not know the name of the patient, nor did we try to know the name because we wouldn't want to know that. The kidneys were donated, both the kidneys and both the cornea were donated, and that in fact gave a life, new vision, new life to 5 more people, and she lives on. She hasn't gone away, she just lives on. It's just not the body that she came to us with. She just lives on through various forms. Probably I'm just going to go to Pune at some point. I'm going to be in a grocery shop just buying something, and I might just have that patient who has received a cornea or maybe a kidneys or maybe a heart next to me. I wouldn't know, he or she wouldn't know. They would be doing their stuff, I would be doing my stuff. That person might have that cornea, they might just see me, they might just cross me. I wouldn't know, they wouldn't know. But yes, there would be such moments which I believe. After all of this was done, this was the tribute that the hospital gave her. Each and every member of the operating team, the guards, the people, the paramedicals, everyone gave her a salute, and she was literally given a heroic send off, something that the soldiers, that is reserved for the soldiers after they return as martyrs from national duty. And she was given a proper send off right from the OT till the point she was taken into the ambulance. 8:46 a.m. is the time I would always remember when her heart was clamped, and that is also the time that was given, her death time. She got a heroic send off, and she is going to be mighty proud of what she has done in the aftermath. These are the pictures of the families who agreed. Over here on the left is her brother Mayuresh, her younger brother, who agreed. This is her mom. This is Sheetal, and this is her dad. It took a lot of effort from them to sign this consent because it is not a small thing to sign the consent. There was still some hope. Her heart was beating. There were non-medicals who were saying the heart is beating. We might still have some hope. There were some miraculous recovery. People were reading on ChatGPT that there have been less than 1% chances, but there are chances that she might have recovery. But we knew practically it was never going to happen. Over here, these are her in-laws. So this happens to be Ajinkya, as I've already shown. This happens to be her father-in-law. This is her mother-in-law, and this is her brother-in-law. This is the family. These are the two families. It took a lion's heart. I would go on the distance and say if it would have been my daughter or my son, my hands would have trembled to sign that consent that we can just go ahead and stop the ventilation. I wouldn't have been able to do that. My hands would have frozen. Despite being a medico, it took a lot of effort from them to agree to this, and they agreed readily. There was just no hesitation, and they know that she lives on, and what she's left behind for all of us happens to be her daughter, whose name is Jiza. This is the first time I'm revealing this picture. This is Jiza. Now, Jiza in Marathi, Jizabai was the mother of the great legendary Maratha warrior Chhatrapati Shivaji Maharaj, and she was a woman who fought all odds, a brave woman who fought all odds and made Chhatrapati Shivaji Maharaj the great warrior that he was. And she's always remembered as the mother who made him the warrior that he was, the person, the man that he was. And she had always wanted that she had a name that she had if a son was born, and she had a name if daughter was born. And she wanted a daughter because she already had a son, and she always wanted, if it's a daughter, let her be named as Jiza. So this is Jiza. She is currently in the NICU. You can see that she is on nasal prongs. She is accepting feeds now. She is being given donor milk, and you can see there's an RT tube in her. She's 1.1 kg. She has just turned 1.2 kgs, 1200 grams. She is in the NICU. She will take time to get out of it, but as her name is, as symbolic as it is, she is a fighter. She is going to live on. She is the next Mao that we have to our family. And I request that everyone who has watched this stream that has been on since the last 1 hour, I would want you all to give her and her elder brother Kian all the blessings, and Ajinkya, her husband, who is doing a great job, not just recuperating from the bereavement that he has had, but also to look after these two kids. He is distraught. I don't think anything can do that can replace the wife that he had, or that can replace the mother these two kids had. But I can certainly ask for blessings and hope for prayers that will always take them through all the difficult times. So this is the story of Sheetal Ajinkya Zambre, or my sister. And I hope this was a session. It was not completely an academic session, but I hope that this session really was something that benefited you all. And I hope you all remember this session as something that was not for academics, but for telling you a memory line. She was there for every event of mine, be it my birth, be it my thread ceremony, be it my results. A lot of my 10th standard, 12th standard results, which were pretty good. She was with me. She was with my family. I always consider to be a lucky charm. And yesterday, as I could see everyone upload their Rakhi images, their Raksha Bandhan pictures, I just knew that this is the first time that I won't have her. I used to send her a lot of these reels on Instagram about brother and sisters, about young babies, about Pune. Pune was my fascination just for her. I used to just go to Pune, fascinated to meet her. All of that, just I know there's a void now, and I decided to do this session so that I would be able to overcome this void. So I hope everyone benefited from this, and everyone knew what could be done, what couldn't be done, and why does this happen. So thank you. This is Dr. Aditya signing off with love for Sheetal, from Aditya and from all our family members. Do bless Jiza, do bless Ajinkya and Kian, and thank you so much. Good night. Signing off.